So for those of you who didn't come to last week's, welcome to the kickoff of our weekly webinars here at Outro. Last week's webinar, we did a more thorough deep dive into the practice of hyperbolic tapering, also with Dr. Mark Horowitz, who's here on the call, our expert and scientific director. Today's webinar, and I believe the next 4 or 5 of them are actually all about like drug specific. So this one's actually on Lexapro, and we'll still be talking about the context of tapering in the hyperbolic manner, but also a bit more descriptive into qualities of Lexapro in the market and the specific mechanisms, how they're available as tapering options, and yeah, we'll get started very soon. Oh, as a reminder, I encourage you all to leave questions throughout the presentation, but I'll give you a 3 to 4 minute heads up before we get into the Q&A, at which I would recommend that the chat be only used for dropping messages in or questions in. That way we can filter through and pick out as many as possible with the remaining time in the webinar. But in the meantime, like last week, find community, share your thoughts with others, let people know, your own story, relate to theirs. There was such good activity in the chat last week, so I encourage you to continue. And on that note, Mark, I think we can get ready. So Mark is calling in from the UK. And I saw that there's a couple of people out in Europe as well that are attending. So thank you all for making the time in your afternoon. Thank you, Mark, for making time in your evening for speaking with me. How are you doing?
I'm doing okay. I'm doing okay. It's a fairly nice afternoon here in London. Shall I go through the slides?
I think we can, yeah.
We've got enough time. So I've been introduced. Emma, do you want to introduce yourself?
Yes, of course. So for those of you who haven't seen me yet, my name is Emma Frati. I'm a newest addition to Outro Health, and I'm really excited to be here, especially after having my own experience tapering off and struggling tapering off of Cymbalta about 5 years ago. That's a bit about me.
Okay, I guess I'll people who don't know me, I'm a training psychiatrist and a researcher. Done a lot of work on how to safely stop antidepressants and other psychiatric drugs. I wrote a textbook called the Maudsley Deprescribing Guidelines that explains how to come off psychiatric drugs step by step. And I guess, as Emma said, we've given some lectures about how to stop drugs in general. And we're going to look at each drug in particular. I guess Lexapro is, I'm not sure if it's close to my heart or the opposite, but it's a drug that I used for 20 years, and I had a lot of trouble coming off it. So I guess it's one that I know intimately well, if not particularly close to my heart. So we're going to talk about a few things today. So if you came to last week's talk, there'll be a little bit of overlap and then a bit more focused on Lexapro or escitalopram. Why do people want to stop antidepressants? Why do people get withdrawal symptoms when they try to stop? What is this rather jargonized sounding term, hyperbolic tapering? And then a few tips and tricks about tapering Lexapro or escitalopram in particular, and then some time for questions and answers. And I think Lexapro is, depending on which source you go to, it's either the second most or in the top 5 most prescribed antidepressants in America. So it's very, very commonly used. So millions of people are on Lexapro. So why should we think about stopping these drugs? This is a figure from, I think, a New York Times article a few years ago, where you can see over the last couple of decades, there's been an increase in people using antidepressants in general, but in particular, what there's been an increase of is this long-term repeated use of antidepressants. So you can see that the red line, people that have used the drugs for 5 years or more, has skyrocketed from 3 million in the year 2000 to more than 15 million in the year 2015. I think it goes up to, and it's even more these days. I think there's more than 25 million people in America who are on antidepressants for more than 5 years. Most guidelines recommend that people use antidepressants for 6 to 12 months. Even those guidelines have been questioned. According to the guidelines themselves, many people are on these drugs for much longer than they need to be. A lot of people are on multiple drugs. We know, called polypharmacy, we know that there are lots of interactions between different drugs that can cause more trouble than it's worth. There are lots of reasons why people no longer may need medication. To unpack that a little bit, we know in actual fact that for most people, antidepressants are not effective. In the most optimistic accounting, the number needed to treat to get one person to respond to an antidepressant who wouldn't have responded to placebo is 7. In other words, 6 out of 7 people given antidepressants in the short term will not have a response that they wouldn't have had from placebo. So a lot of people are not receiving benefit from the drugs. Then there's a group of people that do benefit from the drugs, but because of tolerance to their effects, it wears off over time, and so that benefit goes away. The term used in America is sometimes poop out for that phenomenon of tolerance. We know that a lot of people are prescribed these drugs in the context of something going wrong in their lives. So it's very common that someone gets divorced, has a child, is diagnosed with an illness, goes through a difficult transition like moving to university, moving cities, some sort of stressful new job, relationship difficulties. There are all sorts of triggers that cause people to feel overwhelmed and depressed. And a lot of people will move past those issues, find a new job or partner, mature through a stage. And we see a lot of people who are still on medications 5, 10, even 20 years after the event that unsettled them. And sometimes people are left on these drugs because they are told that they'll prevent a return of people's conditions, and the evidence for that is very mixed. A lot of that comes from studies in which people who are stopped from their drugs feel worse, but withdrawal effects, which we'll talk about more, are ignored. And so it's not very clear whether antidepressants are very good at preventing relapse in the long term. And so they may not be needed for that reason. Patients have all sorts of reasons why they might want to stop. They might find that the adverse effects outweigh the benefits. They may want to try a different method of coping. They may just want to see what life is like without things like the numbing effects of the drugs. We asked more than 1,000 people who were coming off antidepressants why they wanted to stop in particular, and the range of answers was very interesting. It was a bit notable that more than half of them said that they wanted to see whether they could live without medication. And I think behind that is probably, the thought at the back of their minds, have I moved on from my problems? Would things be okay? I don't feel this drug is really helping me. What would life be like without it? Could I be more myself? I think there's a lot of different questions of identity and coping and resilience and ideas of life inside that. Half of people had concerns about being dependent on medication. They felt they were relying on it too much. Maybe that links in with withdrawal effects they experienced when they stopped it. Lots of concerns over long-term effects. A lot of the research for these drugs was very short-term, but studies that are coming out are showing that there are probably significant health effects from long-term use of these drugs. If the drugs are extremely helpful, it might be worth it. But if they're not, it makes these long-term health effects, things like an increased risk of osteoporosis, falls, fractures, cataracts, cardiovascular complications, and even an early death in some studies become a bit of a concern. Some people felt better and therefore no longer needed the drugs. Many people complain about side effects. Many people thought the drugs are really not working anymore, lack of efficacy being the technical phrase there. And there's also of course, a group of women who want to come off because they either they are pregnant or want to become pregnant. And although some of the guidance in America I've seen is very dismissive of the issues that people have when they get pregnant on antidepressants, studies find that people who take antidepressants have 3 times the risk of fetal abnormalities compared to people that don't take antidepressants. So it's from a very low baseline. So without the drugs, there's a 1 in 1,000 chance of fetal abnormalities. With the drugs, it's 3 in 1,000. So it's not a huge absolute risk, but it is a large increased relative risk, and that might be a reason to stop for women of fertile age. One phenomenon in all of this is because people can't find doctors or nurses that know how to help them stop their antidepressants in a way that minimizes withdrawal effects and minimizes other problems, they are leaving mainstream healthcare to go to online forums, which have been helpful to many people. Surviving Antidepressants is the mother of all forums. And then there are places like Cymbalta Hurts Worse. These are private Facebook groups that give advice on specific drugs. And these sort of sites have on them now a couple of 100,000 people. So a lot of people are not being served by mainstream healthcare and are being left to their own devices to work with others to work out how to come off these drugs.
Mark, just out of curiosity here, because I'm reading a lot in the chat of people that have personally tried tapering on their own without clinical guidance. When people are navigating using these online communities, are they typically tapering on their own, or are they looking for guidance to then maybe taper with their clinician?
It's a bit of a combination. So I think a lot of people there are sort of forced to taper on their own because they can't find a clinician that will support them. So a lot of the stories of people who end up on these websites are, I just went and saw my doctor. They told me I could stop it in a few weeks. I could halve my drug, halve it again, and then stop it. But I'm having panic attacks. I'm having electric zaps. I'm jumping out of my skin. Please help me. They get back on the drugs and sometimes settle down, sometimes not. And then these sort of websites say, well, the way to come off the drugs is to do it a lot slower, make small reductions. And some people end up doing things kind of in their kitchen or their bathroom. They sort of become Walter White figures from Breaking Bad, working things out themselves. Others,
Pills.
Crushing up pills, opening up capsules, exactly, sort of setting up entire chemistry sets at home. Some people, I think, sort of get a master's in psychopharmacology to work out how to come off these drugs, which is probably not the case for any other medical condition people have to get through. Other people maybe are a bit luckier, take some guidelines they get from an academic paper on one of these sites, take the Maudsley deprescribing guidelines to their doctor, and sometimes the doctor will play ball and help them and maybe give them a liquid version of the drugs. But so often doctors are dismissive of these sort of ideas. I think it's very hard for doctors to shake what they've been taught for 20 years. If you've been taught it's easy to come off these drugs, I think it's quite confronting for many doctors to change their minds. So I think there's a variety of different responses. Some people find some help, others are left to their own devices. So, there's a lot of talk about the trouble people have coming off antidepressants. And for a long time, it really focused on one thing, which was relapse. That when people come off their drugs, their underlying condition comes back anxiety or depression. And that was sort of that's the main focus of education for doctors. That's what they're very fixated on. And it can happen to some people, probably not as much as the studies suggest, because the other issue is withdrawal effects from these drugs. So we know that when you use these drugs for more than a few weeks, your brain gets used to the drugs. And when you stop the drugs, your brain misses the drug and you get withdrawal effects. And we'll talk a little bit more about what withdrawal effects can be. But the main point on this slide is withdrawal effects are very common in long-term users. So what this graph is showing, I'll make sense of a bit for you. It's a very simple study in which people were asked, how long were you taking an antidepressant before you stopped it? When you stopped it, did you get withdrawal effects? That's the top line and the circles. And were those withdrawal effects moderately severe or severe? That's the bottom line. And the punchline is, if you're on the drugs only for a few months, then most people don't have withdrawal effects. And if they do, they're mostly mild. And that's where the drug companies did their studies. And they put out all these studies saying withdrawal effects are brief and mild based on these short-term studies. And that's what's informed guidelines and doctors. So the reason why doctors have this idea in their head, withdrawal is not a big deal, is because there are lots of studies that are showing that. The only problem is they're looking at kind of this end of the curve. But where are most Americans? Are at this side of the curve. If you're on the drugs for more than 3 years, most people are having withdrawal effects, and about half of them are saying that they're moderately severe or severe. And that's why you have this disconnect between what doctors think is going on and what's actually happening out there in the real world. People should really be able to guess that. The longer you're on any drug, the harder it is to stop it. If you use caffeine for 6 weeks, it's easy to stop. If you use it for 10 years, it's really hard to stop. The same for any drug you can think of. And so people really shouldn't be that surprised. This is true for antidepressants, but I think guidelines have misled doctors a lot.
Yeah.
The other thing, sorry, you go.
No, that was just a good call out, because I think one of the most surprising parts after joining Outro here was also learning that in a lot of the clinical research, when I was trying to understand why I was going through withdrawal after being on medication for years, was that a lot of the studies, the participants were on the medication for, maybe a couple of months. So I wanted to know how you maybe felt about that, especially in the context of how people and how doctors maybe talk about withdrawal, looking at the research, but maybe not looking at how long the patients in the clinical studies have been on this medication.
Yeah, I mean, I think it's sort of evil genius from the drug companies. To me, it's a little bit like if a car manufacturer crashed a car into a wall at 5 miles an hour in a safety test and said, look, it's safe when we crash at 5 miles an hour, and ignored the fact that people are driving around on the roads at 60 miles an hour. And the unfortunate thing is that doctors, are very used to kind of believing what's in textbooks and guidelines. That's how we operate, because, no doctor can do, research themselves or even read all the research or even much of the research. And so drug companies were very clever to get those sentences in the guidelines, brief and mild symptoms, that are very misleading. It makes me think even a bit about the opioid crisis, where, they got into guidelines, not addictive, and that sort of misled a lot of doctors. I think there are similarities here, although the drugs are very different. I think there are similarities here with doctors being misled by the drug company marketing dressed up as research. So let's talk a bit more about what are withdrawal symptoms. Withdrawal symptoms, there is a very long list of them. I think the last count I saw was at least 80 symptoms, because these drugs, they affect the brain, they affect the peripheral nervous system, they affect the gut, they affect almost every organ system in the body. And when you reduce them, you can get symptoms from every single organ that they affect. The symptoms can be cognitive, trouble concentrating, trouble remembering, psychological. I think those are the ones that cause people the most confusion. So withdrawal effects can include low mood, anxiety, panic attacks, obsessive thinking, suicidality, crying. And we know that these are withdrawal effects and not just a return of people's condition, because in studies in which people didn't have a mental health condition but were given antidepressants, so for example for pain or for the menopause or even healthy volunteers, when they stop antidepressants, you can see all of these symptoms. So they clearly could all be withdrawal symptoms from drugs, from antidepressants. And there are also physical symptoms. If on the right-hand side, these are what are called more discriminatory symptoms. They're more different from anxiety and depression, and they make it a bit clearer. So things like electric shocks, akathisia, this very unpleasant sense of wanting to move, agitation, one of the worst symptoms of withdrawal that really can put people in hospital and can make people want to kill themselves because it is such an unpleasant symptom. Dizziness, lightheadedness, vomiting, vertigo, nausea. These are all physical and therefore more distinct from psychological symptoms. It's the psychological symptoms that get mistaken for relapse. So if you're walking into a doctor's office or the emergency department and you say, I've just stopped my antidepressant and I'm having panic attacks and I feel very depressed, the doctor might just stop you there and say, well, it's obvious what's happened. You've relapsed and you need your drug. They may not even ask, are you dizzy? Do you have a brain zaps? Did you have these symptoms before you started the drugs? They jump to this idea of relapse because it is so high up in their minds. And often the story is, no, I didn't have these symptoms when I went on the drugs. These are much worse symptoms, or they're different, or I've got these other weird symptoms I've never had before. And those are all clues that that's withdrawal and not just a return of people's conditions. And I think maybe doctors or some doctors or more doctors have heard about withdrawal effects, but I still think they don't appreciate that it can last for months or years. It can come on a few days after reducing or stopping a drug, but it also can be delayed by weeks. And I think that confuses doctors because they're so ill-informed about these issues, they can miss the diagnosis. And sometimes, this is a more complicated topic, but sometimes if you restart the drug fairly soon after you've developed withdrawal effects, symptoms go away pretty well most of the time. If you wait longer and people develop these sort of protracted withdrawal syndromes, it can be much more unpredictable what happens when you restart the drug. So I guess that's the problem we're trying to avoid. All of these withdrawal effects, which can be severe, can be disabling for some people, can be long-lasting. And so the usual approach to stopping antidepressants is stop it over a few weeks, halve it, then halve it again, and that's what's caused so much trouble. In the last few years, me and other people have worked on a different way to come off antidepressants, very much inspired by what people have learned from these online forums, people like Adele Framer, and we have designed a way of coming off drugs called hyperbolic tapering, which is based on the way that these drugs affect the brain and is now being shown in studies to reduce withdrawal effects and make it easier for people to come off antidepressants. So a whole group of people who were unable to come off with the traditional method can come off with this method. And you might see down at the bottom of this slide, the Royal College of Psychiatrists and NICE. What those organisations are, they're the Psychiatry College in the UK and also the kind of government department that puts out guidelines for doctors in England. And they have both adopted this way of taking people off their drugs. In other words, they are, I would say, years ahead of what's happening in America, where there's been no update to guidelines. And so there's a bit of a divergence between what is best practice now in England and the dark ages, unfortunately, in America. So I'll just sort of make a bit of sense of this. It's a bit of a complicated cartoon here, but I'll try to make sense of it. If you look at the top cartoon, I don't know if you can see my pointer. I suspect you can't. But what is happening is the blue dotted line is someone starts a drug and it builds up in their blood and it reaches a sort of steady state and it stays at that state. The black line is the brain getting used to that level. It adapts, our brains adapt to any change that we have. So, for example, when it's hot outside, we sweat. When it's cold outside, we shiver. When we take a drug that increases serotonin, for example, like a lot of antidepressants do, our brain becomes less sensitive to serotonin. That's the sort of adaptation that it makes to drugs. That whole process is called homeostasis, like staying in the middle, basically. And when you're taking a drug steadily, the brain is sort of balanced to the new level of the drug. What happens here is you stop the drug. This is the sort of third section. The drug leaves your body over a few days or weeks, got rid of by your liver and kidneys. What doesn't change as quickly is your brain getting used to the drug not being there. Although it adapts fairly quickly at the beginning, at the end, we know it can take the brain months and sometimes years to readapt to the drug not being there. And now you've got a mismatch between the black line, what the brain expects, and what the drug is actually giving. And the difference between those two I've shaded in, and that's what causes withdrawal effects. The difference between what the brain is used to and what the drug is actually giving. And it can take months or years for that to go back to normal, and that's why it can take months and years for these symptoms to go away. So the next picture is showing, well, what we can do to minimize that is tapering. So rather than just stopping the drug in one go, it's a bit like jumping off a building. We're sort of now jumping down story by story. So rather than a huge change in the system. We're now breaking it down into smaller steps. And there's still a lag while the brain gets used to the drug not being there, but withdrawal is now smaller. This gray region is smaller. And even better would be to make even smaller reductions. To make maybe small reductions every week or every couple of weeks. There's still some time for the brain to get used to things, but withdrawal effects are much less. And that's why tapering probably minimizes how much disruption reducing the drugs causes.
Actually, Mark, can we go back a slide? I know we're going to do a Q&A, but I think
sure. Please. No, tell me if something's not clear, please grab me.
How do you know when you can go down to the next taper? So I see that you're seeing the area beneath the graph as like the minimization of withdrawal symptoms. And as you're approaching that next taper, you can see that the area is minimized the least, right? The magnitude of the withdrawal symptom. James asked in the chat, and I think it was a great transition before we move on to Lexapro specific. How do you know when you can go down to that next taper?
Great question, and this graph actually does help to answer it. The answer is you should make the next reduction when your body has basically got used to the previous reduction. So, if you look, let's take this graph. Sorry, you can't see my pointer, can you? No, you can't. But okay, look. If you look at the diagram B, the bottom one, look at the first reduction. You can see that at the end of that reduction, the brain has kind of got used to that level of the drug, and it's become, as you said, Emma, it's become thinner and thinner. That's a bit like if you turn that into real life. You go down, let's say you go down 10% of your dose from 20 milligrams to 18 milligrams. You might have a couple of days where you don't notice a difference. Then you might have a week or a week and a half of symptoms. Let's say those symptoms are 4 out of 10 in intensity. Not great, not terrible. You can kind of handle them. Often after 2 or 3 weeks, you might feel the symptoms go down to a 3 out of 10, then a 2 out of 10. That's basically showing you that your brain is getting used to the lower dose of 18 milligram. And so I sort of say when your symptoms are down to a 2 or a 3 out of 10, some people might wait even longer for a 1 out of 10 or 0 out of 10, then you can make the next reduction. If you don't wait for things to get better, you get things building up on top of each other, like a wave on another wave on another wave. And that's where we'll get into trouble. And so when doctors say, why don't you go down from 5 to 0, it's sort of like jumping down 5 stories of a building in one go, and it has consequences for people, for their nervous system. And so, a good judge is when things have settled down enough and you feel stable, that's when you can make the next reduction. So I'll talk a little bit more about, unless there's other questions you wanted me to jump on, otherwise I can talk a bit about Lexapro in particular.
We're good for now. Let's transition over to Lexapro.
Okay, so I'm going to focus in a bit more on Lexapro in particular. I want to talk about mechanism. When we were putting these slides together, Emma chose the sort of textbook explanation, SSRIs target the serotonin transporter. And that's true. But I also think there's a difference between what antidepressants do and how they have an effect. They do lots of things. They affect serotonin. They probably affect downstream processes. They affect receptors and signaling processes. I think, though, that the most common thing that people say who take Lexapro and other antidepressants is they feel emotionally blunted, which means that their normal range of emotions from very positive to very negative is squashed into the middle. And when people are very panicked or very anxious or very depressed, having the volume turned down from a 10 to a 3 can be a great relief. But it's also one of the main reasons people want to come off these drugs, because they feel that it affects their sense of self, their relationships. People lose interest in things they previously had an interest in. And I think that most people are not told that is what these drugs probably do. They are told these drugs fix a chemical imbalance, which we can get into is essentially been debunked. It's never really the case. And I think that people, if they were told that these drugs really affect the normal functioning of the brain by changing its chemical balance, they are themselves really causing a chemical imbalance, and that's probably what causes the numbing, then people might be a little bit more reluctant to use these drugs long term, because I think everyone has a sense that things that change the chemistry of the brain may not be that great in the long term. In terms of the risk of withdrawal, Lexapro's in the middle. It's not as bad as drugs like Effexor or Cymbalta, but it does clearly have a risk of withdrawal. In studies, short-term users, like I showed in that other graph, have a smaller risk of withdrawal, only 1 in 5. But once you're looking at longer-term users, it's 3/4 of people. So it's very common. It's the rule for long-term users, but the exception for short-term users. It peaks in 4 hours. It has a half-life of 30 hours. That's the time taken for half of the drug to be removed from your blood by your liver and kidneys. That's important because some people try to come off these drugs, or doctors recommend it, by taking the drug every second day or every third day. And it sounds like a fairly sensible way to come off the drugs, except that because the drugs half basically every day, if you wait 2 days, they half and half again. So you have a quarter of the drug in your blood. And that causes big up and down in people's blood levels, and that can cause severe withdrawal effects. That's one of the reasons why people get into trouble when they go to most doctors on how to reduce these drugs. The tapering, I'll show you a graph in the next slide that'll make this a bit more obvious why linear tapering versus hyperbolic is problematic. And there are various different options to make it easy to taper. There's liquid versions of the drug, or you can compound capsules or liquids, and I'll make a bit of sense of why you might need to do that. So this is, I'll make sense of this. Sorry, I'm bombarding you with graphs. This is neuroimaging of the effect of Lexapro on the brain. You can think about the y-axis as just effect on the brain, and the x-axis is dose, 5, 10, 15, 20 milligrams. The main point of this black line is it's not a straight line. So doubling the dose from 10 to 20 doesn't double the effect on the brain. Actually, it's not that big a difference. And even a little tiny dose, like 2 milligrams, which a doctor might laugh at and say it's homeopathic, actually has half the effect of 20 milligrams, much bigger than you would think. And the reason for this relationship is the law of mass action, which is a technical way of saying when there's not much drug in the system, all the receptors for the drug, all the kind of parts of the brain that the drug interacts with, are open for business. And so every milligram of drug has a very big effect. And when more and more of the drug is there, these receptors become occupied by the drug. And so every extra milligram has less and less effect. A bit like the game of musical chairs. It's easy to find a chair at the beginning of the game and much harder at the end. So you get this sort of law of diminishing returns. And this shape happens to be called a hyperbola. And what it allows us to understand is what happens if you follow most doctors' advice on how to come off the drugs. So an example might be, they might say, look, you're on 20 milligrams, go to 15 for a couple of weeks, then go to 10, then go to 5, then go to 0. It's quite simple, the maths. You can do that with tablets. There's 20s and there's 10s and 5s. So it's very simple to do with tablets. It's just very hard on people's brains because when you go from 20 to 15, there's only a small change in effect on the brain. Some people find that okay. Other people find that quite unpleasant. 15 to 10, it's a bigger change in effect, more unpleasant. 10 to 5, bigger again. People can find that quite unpleasant. And then from 5 to 0 is like jumping off a cliff. It has about 20 times the effect of going from 20 to 15. And this is exactly what patients say. The first few milligrams are the easiest to come off. The last few milligrams are much harder. And when doctors are not aware of this relationship, they can conclude the person must need the drug, they've relapsed, they're in a terrible way. And so what makes more sense is to reduce by even amounts of effect on the brain on the y-axis. And that corresponds to smaller and smaller size reductions in dose, going down to tiny little doses, like less than a milligram before stopping, so that you don't get that jump that you get in this, what's called linear tapering. And so you have this smaller and smaller size reductions down to tiny doses before stopping. And because this graph is called a hyperbola, that's called hyperbolic tapering. And it's basically saying at the steep bit of the curve, go down very slowly. If you imagine that this was like a path in the woods that you're walking along, you'd start off fairly quickly because it's fairly flat. it gets steeper. You've got to go a lot slower. And when it turns into an almost vertical cliff, you've got to climb down inch by inch. And that's what hyperbolic tapering essentially is.
Yep. Everyone in the chat right now is actually, not everyone, but there's quite a few people in the chat right now that are attending the webinar and speaking on how these last few milligrams were the absolute hardest for them, and that there was disbelief or a lack of trust with their providers. It said, oh, well, you're on such a low dose, it shouldn't be so difficult now. And even in my experience with our discovery calls with potential patients at Outro, how many times we hear that story, it's heartbreaking.
Yeah.
Because the opposite is true. Yeah.
So exactly. So doctors are unfortunately, mostly not aware of this relationship, and they think that these doses are very small, and they mistake the fact that actually this graph gets steeper at the end. It's actually harder to come off the last few milligrams than it is to come off the first few milligrams. I think Chris has commented this is the same as the citalopram chart, slightly different. It's 5 milligrams of Lexapro equals about 10 milligrams of citalopram, and this has been derived from neuroimaging. But yes, it's unfortunate that doctors, I think what the mistake they make is when they say you're on a very small dose, what they mean is you're on the smallest tablet or capsule of a drug, but they don't, the brain doesn't care what size tablet you put in your mouth. It only cares the effect on receptors. And so doctors are mistaking a small tablet for a small effect. And that's where they get into trouble. So I won't go through all of this. This is just an example. So basically I've turned these graphs into into a table to show you what tapering might look like. And this is taken from the Maudsley Deprescribing guidelines, a handbook we put together on how to stop all these different drugs. And this is similar to the kind of tapering we would oversee in Outro. And so you can see that at the beginning, this would be what I would call a faster taper. This is for somebody with less risk factors. Maybe they've only been on the drug for a year or two. They haven't had a lot of trouble coming off in the past. And so this would be something like, start off by making larger changes at the beginning using tablets or half tablets. But at some point you get down to doses that are smaller than you could make up with a tablet, and you need to swap to a liquid. There's different liquids available. It tells you how much volume to use, and you could go down all the way down to 0.3 milligrams, that very steep part of the curve before stopping. There's also options, what I would call a moderate taper. Maybe someone who's been on the drugs for more than a couple of years, had trouble coming off. This is a slower taper. They might do this step every 2 or 4 weeks. Again, starting off with splitting up tablets and then going down using a liquid all the way to the end. And for people with real trouble, this might be someone who's been on the drug for 20 years or more. They've had huge trouble in the past coming off. It may take them a lot longer to come off. And there's even more steps going all the way down to a tiny fraction. The last dose here is less than 0.1 milligrams to get off, again, going down very slowly at that very steep part of the curve. And to summarize that in very kind of broad brushstrokes, you can go a bit quicker at higher doses, but broadly speaking, kind of fast taper would be going down at 15 to 20% of your most recent dose every month. Moderate or medium taper might be 10% of your most recent dose every month. So as you get down to smaller doses, it gets smaller and smaller, because 10% of 20 is 2, but 10% of 5 is 0.5. And for people that have real trouble, a slow taper would be 5% dose reductions of the most recent dose for people that have the most trouble. So I think that's the end of the formal part of the talk. I'm happy to take questions or answer. If people want me to answer these questions about my own journey off Lexapro, I'm happy to talk about that.
I think most of the ones on this slide are actually the ones that were in the chat. The only one that's missing here that I also wrote down that we've gotten a couple times from Mary as well recently was what was your last dose of Lexapro before you went to full discontinuation? Oh, it's here. It's question 3.
Oh, okay. So, all right, I'll answer these questions as best as I can in a few minutes. I took Lexapro for a very long time since I was a wayward 21-year-old, and I've stopped it actually now a few months ago, and I'm a slightly less wayward person in my early 40s. So I took it for about 20 years. I tried to stop it on 2 occasions in a serious way. A few times I tried to stop it without thinking about it much, and always felt kind of terrible. Went back on it. Never thought about withdrawal effects. Just assumed I needed it, like everybody else walking around. I tried to stop it once when I was in my early 30s, about 10 years ago, and almost all the symptoms that I put up on the slide I had. I had trouble sleeping. I experienced, I think it was sort of mild to moderate akathisia, a lot of agitation, a lot of terror. I took up running. I ran until my feet bled because I was so terrorized by what I was feeling. It made me feel a bit better. I spent hours and hours meditating a day to try to get through it. I felt dizzy. I felt that things around me were not real. Sort of derealization, depersonalization. It's definitely the most horrifying experience of my life. Those few months where I was in that.
How long after complete discontinuation do you feel like your withdrawal symptoms subsided, or do you feel like they ever completely did?
So after that time, I didn't get off the drug completely. I sort of my brain exploded when I got down to about 1 milligram. So I never got off the drug. I ended up going back on the drug then because the symptoms were so unbearable. I could only stand that state for a few weeks before I gave in to going back on the drug, and I stayed on it then for a couple of years afterwards. My symptoms, I think, very luckily, mostly did go away after a few months of going back on the drug. Then the last time I tried to come off the drug has been this time when I took it a lot slower. I basically followed a lot of the guidelines that I put out here. I went according to the slowest taper that I showed, really by 5 or 10% per month. It took me, my story is a little bit more complicated, I think, than the average punter because I was on multiple drugs, but it took me 5 years to come off, 4.5 years to come off Lexapro amongst other drugs, whilst working full-time, actually working very hard, so having quite a busy life. And I've been off Lexapro now for about a year. And so what was different with each attempt? I mean, the first attempt I came off in 4 months. I thought that was very slow back then. I was very naive. And this time, I took years rather than months. That made the big difference. What was my last dose before discontinuation of Lexapro? I started off doing the kind of slow taper that I put up as the last slide. At some point, I actually went into a micro taper where I made lots of little reductions every day for the last year or so. So my final dose was 0.001 milligrams. I didn't take any risks. I went right down to that last, down that very steep part of the curve. I went down, whisker by whisker all the way to the bottom.
And I asked you this last time, but I think it's a good question still. Do you think everyone, because there's people in the chat talking about different conditions, different diagnoses. I have a follow-up question actually about someone who wrote something about a recent ADHD diagnosis, but also Mel currently is going through perimenopause, and she was wondering if she can taper off of Lexapro. And I think for the broader audience would be, do you think everyone has the capacity and capability of getting off their antidepressants?
I think it's a bit of a nuanced answer. I mean, I think, does anybody have a condition that requires antidepressants? I think the answer is no. Sort of question is, if you lack thyroid hormones, do some people need thyroid hormones? I think the answer is clearly yes. And there's a story that's been told to people that, if they're depressed or anxious, they've got a serotonin deficiency, they've got low serotonin or a chemical imbalance, and they need the drug. We didn't talk about that very much, but that's, clearly not the case. People don't have low serotonin when they're depressed or anxious. It was a hypothesis put up decades ago, very much amplified by drug companies, hasn't been proven by research. Nobody.
We did another webinar debunking that one.
No one has a frank, lack of serotonin that they need the drug for. But not needing the drug is different from can they stop the drug. So, I think it's true that no one needs the drug, but stopping the drug can be disruptive for people. It depends on how you do it. The slower that you do it, the less disruptive it is. So, I've learned that from my own experience. I couldn't stop it over 4 months. I could stop it over 5 years. I think a lot of people who have tried to come off have tried to come off too quickly and got into trouble. I also think that some people's circumstances, do make it difficult. If you're very, very stressed, if you don't have space in your life, it can be hard to accommodate more stress. So I don't think that everybody's in a position where they can come off it. Ideally, it would be better to come off at an easier point in life. But for some people, there isn't. Life is an ongoing disaster for a lot of us. It's not always easy to find a perfect point. I think there is another aspect where I didn't talk about it, but very much. But for some people, I think antidepressants can make things worse. So I think sometimes the side effects can outweigh the benefits, as I sort of mentioned. But also, I think there's a growing kind of literature research around something called tardive dysphoria, which is this idea that long-term use of antidepressants can actually make some people's anxiety or depression worse. It's a bit similar to opioids. I think it's a bit better known that sometimes long-term use of opioids can make people's pain worse. So, even if people are not necessarily in the greatest position, sometimes stopping the drug may actually benefit them. So I think there's sort of lows, and some people have said to me, look, okay, the drug works by emotionally numbing. I want to be emotionally numbed because life is so difficult. I think that's, a reasonable choice to make. But I think a lot of people have not been told that is how the drugs probably work. So I think there's sort of an informed consent aspect where people have to understand how effective or ineffective the drugs are, what withdrawal effects look like, what alternatives are for managing their conditions, and how the drugs work to make an informed decision. Is this the right moment in your life to try to come off the drugs or maybe not?
Yeah, those are all great points. I think from there too, since we have 10 minutes left on the clock, we can get to the end of the couple last slides. And then everyone in the chat, if I have not answered your question or brought it up to Mark, please drop it in the chat so we can try to address everyone's questions, especially if they're Lexapro specific, since this is your opportunity in the drug specific Thursday webinars to really get some insight.
So, Outro is a digital clinic that I've helped to set up, and we really set it up because after I started doing all this research, I was inundated with thousands of emails from Americans mostly asking me to help them come off their drugs. And they wanted to know who were clinicians they could go to see. And there is a very small number of people that understand this in America. And so we wanted to create a place where people could go to see people that understood how to come off these drugs in a safe way. And so it's a digital clinic where we design personalized hyperbolic tapering plans for people. You see a nurse practitioner regularly. You can contact them if things go wrong in between visits. You can monitor your withdrawal symptoms so people know what's going on. We have a good relationship with different compounding pharmacies to make up the smaller doses of medications that people need to get off the drugs. And we have a suite of different educational bits for lifestyle medicine to help get through some of the difficult bits. And so, what does a kind of flow through our clinic look like? People are screened for their eligibility. Are they? Can we look after them well enough with a digital clinic, or do they need more support? What's been their experience of coming off the drugs in the past? What have been their issues? They get assigned to a nurse practitioner that I've helped to train with some of the other psychiatrists and specialists. You can see some of them down there. People like Adele Framer, Brooke CM, who's written about her trouble coming off antidepressants. So we have a very well-informed group of clinicians. Then we create a personalized taper plan based on risk factors, how long you've been on the drug, your past experience, which drug, your dose, and then we would start the process where that involves ordering compounded medication. We'd get you to monitor your symptoms. We'd follow up carefully to make sure that things don't go wrong. I think that's one of the special sources is rather than just sending people off with a list of doses, we check up on people very carefully so we can monitor and adjust the rate of taper to make further reductions. And we are open in several states. My geography is not good enough to remember what those states are, but Emma will know.
That's going to be Florida, Texas, Colorado, California, and Washington.
Right. And we're opening in New York in the next few weeks. Is that right?
Yes, in the coming month.
Okay, that's exciting. So I'm happy to take a few more minutes of questions if that's useful, or if people are exhausted, that's also okay.
Yes. So I also have a question in the chat here. I'm going to speak on it. I realize that my ADHD, recently diagnosed, is the primary reason for most of my anxiety/depression. I've been with a therapist for about 5 years since my withdrawal, and working with the ADHD has been really eye-opening. I would love to come off completely to see how I can manage. Do you have any comments on that question?
So I'm not exactly sure, what they're talking about coming off completely, whether that means stimulants or antidepressants. I guess I'll just say a couple of things about the general topic that relates to outro the most. I think number one is, antidepressants clearly cause concentration and memory problems. That's been shown in healthy volunteers that are given antidepressants. It's on, if you open up the patient information leaflet, the little piece of paper inside most antidepressants, you'll see that it lists as a common side effect concentration problems. So I think that's a bit of a concern because there are 50 million Americans walking around on antidepressants that cause concentration problems. And there's now a surge in diagnosis of ADHD. So personally, I think you can't really receive a diagnosis of ADHD while you're on an antidepressant, because if you're on a drug that causes concentration problems, then surely you have to remove that confounder in order to make a diagnosis of ADHD. But I think that generally doesn't happen. People are sort of added on another diagnosis and then more medications. And that can lead to a little bit of a cascade because, of course, the treatments that are given most often for ADHD are stimulants, which are basically amphetamines. The amphetamines can cause anxiety and depression. And then you're given maybe more antidepressants that might make your concentration worse. So it can lead to a little bit of a spiral of increasing medications. So, and then the other complicating factor, to talk to the question that was asked, if I'm getting it right, if she's been in withdrawal from antidepressants, withdrawal can itself cause cognitive problems, which can make concentration harder. So again, it's a bit difficult to untangle what is due to withdrawal from antidepressants, which can last for months or years, like I mentioned, and what is concentration problems de novo. And I do think that it's often simple for people to have less drugs on board to try to work out what's actually going on versus what is the drugs. And it gets very confused when you have multiple different drugs around and withdrawal effects. It does make it hard to discern what's going on.
Yeah, most definitely. I think that was one of the most surprising situations for me, as well as when I was taking the antidepressants, that I started to have concentration and memory fog and a lot of difficulty just with concentration in general, staying focused, especially as I was in school. But there's a question in the chat now from Kira. Is there anything that can be used or taken to help with the tapering process? And I'm also I'm not a clinician and I'm not a medical doctor and I'm no expert in tapering, but I will mention something that Mark said that I also am a huge believer in, was physical exercise, especially through the tapering process, was so important for me. I know it's not a supplement, so it's not something that you necessarily can replace your medication with in the morning or at night. But I found it to be the biggest part of my healing journey, getting off the medication, the polypharmacy, because it wasn't just antidepressants, was being physically active throughout the day, be it, taking breaks when I was sitting at my desk and making sure I took a walk outside, or doing a floor workout in my apartment in New York, or going running, which is for me was the best until I got a flare of tendonitis in my left knee. But I was running every morning, and it really helped me stay centered on myself. And my goal every day was like looking to tomorrow and saying, I really want to get off this medication, and I don't want it to be a crutch, and I don't want to go back to it just because the process of getting off was so difficult. And it was toying, but for me, it was physical exercise. And I'd love, Mark, for you to comment on if there's any supplementation or any way to, enhance wellness activities through the tapering process.
So I'll try to finish on time here. Look, the question that people always ask this question: what can I take to get off the drug more quickly? What you're really asking is there something that you can do that will make your receptors or the genes that are affected by the drugs normalize more quickly? I think about it as your brain is recovering from the effect of the drugs, almost like recovering from an injury or an irritation to the brain. And so I sort of say it's similar to the answer of, if you broke your leg, can you make the healing more? Can you make it happen more quickly? And the answer basically is no, because you've got to grow new bone cells when you've broken a leg. You've got to get rid of old bone cells. You've got to grow vessels. You've got to grow skin and the fibrous coverings. And it's a biologically determined process. And there is no real supplement or drug or procedure that you can take to make a bone heal quickly. Okay, it's good not to be malnourished. It's good not to bang the bone again. It's good to be generally healthy. That's useful. And I think the same thing applies to withdrawal. It is good to be generally healthy. It is good to exercise if you can. Some people have already written in the chat, what if you're too sick in withdrawal to exercise, which is often a problem. It is good to eat well. It is good to try to practice mindfulness, anything that will reduce stress. I think that can make the process a little bit easier. But really, there's no way to speed up the natural process of recovery of the brain. And so unfortunately, everyone wants to have what's the quick fix, what's the magic bullet, what will get me off this in 6 weeks. Unfortunately, the only thing that seems to work is going slowly enough down on your medication that doesn't cause huge upheaval in your nervous system and therefore your life. So I think it is good to do anything that reduces stress and anything that keeps you well, anything that keeps you balanced. And there's different things for different people. It may be mindfulness or exercise, but I don't think there's a magical supplement or drug that can help you get through it. And I think it's important as well. I think withdrawal effects are an important signal. It's telling you that you're going too quickly to come off the drug and you need to slow down. I'll just give you one more analogy before we close up here. I think also another analogy for coming off drugs is altitude sickness. And when you go up a mountain, the pressure changes very quickly and you can get altitude sickness. If you rush up a mountain, you're more likely to get altitude sickness. If you do it slowly, you're less likely. If you start to get signs of altitude sickness, it's not good to suppress them. It wouldn't be good to take a drug that would make those symptoms less. You want to know, because it's a signal that your body can't handle that rate of going up the mountain. I think the same thing applies for antidepressants. If you're getting withdrawal effects, it's a sign that your brain can't cope with the rate you're going at and you should slow down. And so rather than trying to find something to suppress it, you should take the signal and take the feedback.
All right. I think that was a great note to end on. We're going to be ending this webinar now, but I encourage you all to follow us on our socials to keep up with the next webinars that we have coming up, and also any of the other educational content that we'll be promoting there as well. And if you're in an active state right now, tapering Lexapro, I encourage you to sign up for initial consultation with Outro if you're in an eligible state. And if not, sign up for our waiting list if you're here in the US, because we're here to help you. And just so anyone knows, if you're interested in any other drug-specific webinars, next week we'll be meeting with Dr. Brian Shapiro, and he'll be going through his own research, walking through Cymbalta hyperbolic tapering, and his own personal experience as well. But Mark, I want to thank you so much for joining me. I want to thank everyone here in the chat for being so active and leaving so many great messages. I hope we were able to get to everything. And if we were not, tune in for the next ones, drop your question again, and we'll see you there.